Good morning, everyone. Thank you for
Um,
joining. Leah's jumping in with us, so I'll give her the baton to take off.
Sounds good. Good morning, everyone, or good afternoon, I guess, depending where you are. Sarah may have mentioned, this laid plans this morning. We had a little bit of like a hiccup with just trying to get on the Zoom sort of like system as we all are used to doing it. So Sarah and I will be moderating ourselves this morning. So, which means we have no control. No, I'm just kidding. It simply means that just like usual, if you've been in these webinars before, there are other folks that are kind of monitoring questions and things like that. So if you have questions, feel free to put them in the chat. We will have folks kind of moderating, answering some of those questions, and then we'll try to keep a lot of time at the end for questions as well. So again, good to sort of see everyone. I guess not really see everyone, but good to see everyone, at least virtually. I'm going to go ahead and share the presentation. Sarah's going to let me know that she can see it, and then we'll jump kind of right in. We're excited about this topic this morning. It's going to be awesome. All right.
We're good, Leah.
All right. Sounds good. Sarah will give me like the smoke signals or whatever. If there's anything that goes sideways, y'all just like let us know. So we're going to jump right in. So today's topic, we're going to talk about, skin protection of the skin, techniques of protecting skin integrity. As we all know, every time we touch a patient, that's what we're dealing with is that skin and really sometimes that unpredictable state of the skin. So we're going to start and kind of jump right in. We're going to give you our backgrounds. Sarah and I have both been in the field for a little while. Me a little bit longer. I've been in the field probably older than a good chunk of you have probably been alive. I've been in the field now for about 40 years. And so it's been a while. So, if there's any historical questions you have as we go along about how life was before digital and other things, I can actually give you some insight on that, sad to say. Sarah's got great background. She comes with that strong clinical background. She comes with sort of that today's, insight on what's happening as well. And that's why she and I like to tag team these presentations together because we feel like we can bring a little bit of both sides of the fence. I've spent most of my last several years or 20 years, not several, but 20 plus years in medical device. Sarah has medical device background as well as super strong clinical background in all facets of services, whether it be a direct clinician, whether it be in various settings, whether it's been on the corporate side, education side, all those type of things. So as you go along and have questions, feel free to shoot them out there. If we don't know the answer, we'll tell you we don't know it. We're going to give you that information or at least as many resources as we can. So with that, we're going to go ahead and hop right in. So the big objectives that we're going to do today is, we're going to talk about the skin and we're going to talk about hopefully sort of in-depth conversation about skin and skin integrity, just so that you kind of have like a better feeling and comfort level with what you're dealing with when you go to approach that patient for any kind of electrode or medical device application. And particularly, of course, in the land of EEG, we know that we've got challenges. And I know I spent about 12, 15 years in clinical before I jumped to the corporate side. And if I would have had some of this knowledge, because I spent most of my life in pediatrics, if I would have had some of this knowledge on skin and what skin is all about, it would have helped me immensely on being a better clinician and really like protecting that patient's skin in a better, more thoughtful way. So we're going to talk all about the skin. We're going to be all in on it. We're going to talk about devices with the skin. We're going to get familiar with those devices. And then we're going to talk about the interaction. And then we're also at the end going to bring in some effective techniques, experiences on how to protect and safeguard that patient and that interaction of like electrode to skin health. So jumping right into the skin. So, as we look at the skin, obviously we know that different patients have different skin issues. But the one thing I think that we also need to make sure we always understand is just these layers of skin that we're impacting. This integrity conversation is one that if you're not hearing it in your clinical service, you're going to be hearing it as time goes on. Because we as the neuro team, as the clinical neuro team, we're becoming a conversation outside of our specialty in the land of, wound care, risk management, more than you ever, might imagine. And part of that's because there's better tracking now on skin health. And so, you put a device on skin and you're going to have some challenges. And so, because of that, our understanding of it becomes critically important. So we got functions of the skin. I think we all sort of know a little bit what skin does for us. It's our biggest organ. It's really all about protection. It really is this barrier that tries to protect the rest of our body from all these things. And we get impact from everything internal, meaning to the body of the patient, also external impact, but things that you may or may not think about on a daily basis, or maybe you think about it, but maybe we're not thinking about it maybe enough. We've got this protection barrier. We've got temperature that impacts the skin. The skin helps with sensation. I mean, sensation of, if you've ever heard of those rare cases where if someone can't have sensation through their skin, they can burn their hands on, a stove because they can't feel, they don't have that sensation of the danger of the heat. So it gives us this protection of sensation. It, gives us all kinds of wonderful metabolic functions, produces this vitamin D. And then, of course, obviously, it helps us regulate. It produces, gets rid of all the waste like these salts and other things through sweat and, other ways that can manage our temperature. So skin has a big job. And, part of the reason it's got a big job is because it covers us really from top to bottom. Now, does that mean that our skin is the same from the moment that we're, born to the moment that we're no longer here? The question, of course, and we know that is the answer is no. The skin changes, and how it changes should affect how we approach the patient. So, when it comes with age, and by age, it means, tiny little age, like, neonate right at birth. It also means as we get older, our skin gets frailer, it gets thinner. We're going to talk in a minute about why that happens. Circulation can be impacted. Certain medications, skin thinning drugs. I'll tell you this quick story. My daughter was about 14. She, started, went to a dermatologist. They put her on an anti-acne medication. Then I wasn't aware of it because frankly, it wasn't mentioned. My niece was in cosmetology school and she wanted to do a kind of a test run on doing waxing of eyebrows. And so if anybody has had this done, you know exactly what I'm talking about. They put warm wax on your eyebrows and they kind of rip it off your eyebrows. The thing was, because Lexi was on a skin thinning medication, it took the top layer of her skin with it. It was the most horrifying thing any of us had. I was like, oh my gosh, I thought my niece had done a bad job. Here I found out it's just because Lexi was on that medication. I didn't know about it. My niece didn't know to ask about it. My daughter wasn't aware of it. So it was a lesson learned. By the way, she healed up beautifully, never knew it even happened. But any kind of medications, can have impact on skin that can be significant. Obviously, diseases can have impact. And then we've also just got external. We've got scratching. That's that mechanical damage sometimes of whether it's from a device or just from the patient themselves, pressure. And these are the things that should start sounding pretty familiar to what we do. And that is pressure, prolonged pressure on the skin that is at risk of skin integrity issues, moisture, and then chemical exposure. So irritants, allergens, all kinds of things, which is all kinds of stuff in the products that we use. So all four of these things listed under external are things that we really need to be aware of when it comes to the patient, in addition to what's on the left side of that screen. So the skin, it's built to protect. It's the largest organ of the body. It's got these layers that we want to be familiar with. The one that we want to be most familiar with is the epidermis. So that's that most outer layer of skin. It houses this layer that's called the stratum corneum. Hopefully I'm not destroying that pronunciation. If there's any dermatologists in the room, I apologize because I'm always working on that one. It houses that layer plus another layer underneath. But these little layers of the epidermis are kind of what you might see impacted, if you scratch your skin really hard and then you see that flaky skin. That's what we're impacting is the epidermis. Then underneath that layer, you've got the dermis. That's where your collagen is, and that's where you get that strength. And then beyond that, you get your hypodermis or your subcutaneous tissue. Those of you that have been in the OR, you've got subcutaneous needles. This is where it's kind of by definition, kind of telling us how deep that subdermal needle is going. So it kind of like, all of this starts to kind of make sense as you think about the skin and how we're impacting it. The epidermis, there are some things about it that we need to be aware. Even though we have epidermis, on every little, tiny inch of us, there's different thicknesses. And that makes a difference if you put a device or an electrode on that skin. So you've got these thick areas. Sometimes when I first got into EEG, of course, as we all kind of do, I saw that kind of bald guy come in and I was like, yay, give me that patient. Okay, that was the worst thing because as you all know, trying to get your impedances to the level you want on somebody with lesser hair, like a bald patient, is a lot more difficult. And the reason it's more difficult is because they get this extra layer of, of under the epidermis called the stratum luceum. So again, apologies for the pronunciation for dermatology people out there, but you get extra layer that sits underneath. And if you've got this sort of hairless, thicker area, that's the reason for it. You got these extra layers, and that's what causes it to feel thicker, harder to get your impedances sometimes. If you have thin skin, then you've got a lack of those extra layers of protection. So that's where if and you probably all have, if you worked on older patients who just scratch their leg, boy, they can like scratch their leg and start bleeding like crazy. And it's because they don't have those extra layers of protection. Collagen gets impacted, all kinds of stuff. So, that's why when we look at our patients, we need to take into account the age. We need to take into account the medications they're on. Ask questions about the skin if you can before you get into the room with the patient from the nurse or the patient themselves. But definitely be aware if you're putting leads on spots where there's not a lot of hair, you're likely going to have this like thicker skin. And vice versa, if you've got an older patient or some area that's more susceptible, you could have really thin skin as well. Again, just a little graphic of that. It shows kind of those thicker layers of those palms that like for instance on your feet, hands, things like that. Thinner skin. Also as noted here as well. It just kind of gives you like a little all that impact of that skin layer. So, now that we start to understand, especially again, this is all part of that most outer layer of the skin, which is the epidermis. Once we understand the epidermis, we especially make sure we want to understand our thin-skinned patients. And again, this is just a natural progress. As much as I wish, like at my age, I could look at my hand and not suddenly like see my mom's hand. Like that, I mean, that's all of a sudden you kind of go, holy cow, or you look at it like your legs or something, you go, holy smokes, when did that happen? That's just from aging. It's just an aging process. And so what you see like in that picture, that's why you get bruising and that's why you get shearing and tearing. The reason we care about this as we go into this next slide is because anytime that we need to apply an EEG electrode, we have to do, as we all know, a step of preparation first. I wish at this point of the world, we all lived in a world where we could just put leads on a patient, don't have to do any extra prep work. We can just put the lead on and ta-da, we have beautiful EEG. The reality is we know that is not possible. We have to deal with the skin and we end up impacting the skin because of the prep technique that we have to use to get good data. So when I prep the skin, I'm using any product and you can pick any product. You can pick, your new prep or you can, pick any kind of like prep that you want, but take a look at the label. It's going to say that it's an abrasive and it's got to be an abrasive. It's not like we have a choice in this, but it's going to be an abrasive. Now, when you abrade the epidermis, you have now created, by definition from the CDC, you have now created non-intact skin. Once I have non-intact skin, whatever device I touch to that non-intact skin matters. And it matters because of what you see on the screen. If I put, some medical device, EEG electrode or some other device on that non-intact skin and it sits there, and I've got moisture in there, as we just talked about, impacting that skin health. I've got pressure. I've got, something holding it on. So I have some kind of, chemical or, something that's also touching that non-intact skin. And now I have no protection of the skin for what's underneath that first layer of epidermis. I will introduce the risk of having pressure injuries. And, this can be a full presentation in its own. We're going to kind of move on it. And if you have more questions at the end or you want more information, let us know. But, as soon as you start seeing any redness at all, you've entered the land of skin integrity degradation. So it starts moving into stages. And that's why your nursing teams get involved. The risk management team gets involved. If it's really bad, you're going to have your wound care folks involved. So just be aware, there's no way for us to avoid it, but we can get better at what we do. Now, one way that we get better at what we do is we have to understand that electrode that is touching the non-intact skin. Shape matters. And we're going to talk about shape in a moment to a bigger degree, but whatever product you're using, look at it with a very critical eye. Look at it from, what is touching the patient's non-intact skin. Because now we've got some great guidance on what kind of products should be used, the shape that they should be used. Great studies have been done in the past 10 years, which has been awesome. But now we move into, we understand the skin, we understand the challenges. Let's look at those electrodes. We want to use electrodes that have the least amount of pressure as possible on that non-intact skin. And I remember I keep using non-intact skin because if you prep the skin, it doesn't matter how aggressive or even careful you did it, you have impacted it, period. We can't get around it. So you did your prep. That next step is look at your electrode options. Look at where pressure is touching that patient. Even ASET took this on, which was fantastic. It now has been, oh gosh, probably over 10 years ago that a task force was created because skin health started to kind of become a highlight in hospitals and services to such a degree. It was time for our organization to kind of get in this conversation as well and start talking about the skin. So they created a task force, which was fantastic. First time ever, really, in a sense, the creation of our industry, that we really took an official stance on skin. So if you don't have access to the ASET skin recommendations, it's on their website. You can get it for no charge. It is really, really good information. And we're going to touch on a few things here in a minute as we roll along. But as you're moving through that information that you're reviewing from ASET and others, if you're not following these guidelines, talk to your administration, talk to your manager, talk to your physicians, talk to everybody and anybody around you as to why you should be doing it. Because, this has got a lot of background, a lot of research behind it. There's some great videos now as well. So again, you can get right on their website. And, they're talking in the language that we know is reality, meaning, we can't not do it. Meaning we have to get our study done. At the end of the day, we have to get a good study because it also doesn't do anybody any good for any of us to say, oh, we protected the skin. Oh, by the way, you couldn't get anything out of that EEG because it was so filled with artifact. But hey, the skin looks fantastic. That's not an option either. So, we are in a spot where we are kind of sitting in a little bit of a moment where we have to balance both. One of the things I want to show you from this ASET task force is that they recommend a flat-rimmed electrode. I was ecstatic when I saw this come into the documentation. I have been kind of like a weird student of skin now for about 15 years because I find it so interesting, and I find it so interesting as it relates to us in our field. So the fact that they listed it, and what they mean by that is they're talking about, when we talked about in those first couple of slides, we talked about that, that pressure. If we can alleviate some of that pressure on that non-intact skin, that flat electrode is going to perform better to protect that skin and its integrity. It also talked about right under that, like thinner, less heavy wires and cables, again, to reduce that pressure. So it's got some great tips in here. The one thing I'm going to touch on just for a quick second is impedances. So if you're someone like me who's been around forever, we've gone through impedance conversations up and down for the past 40 years. When I entered the field, the goal was to get them under 5. And ideally, if you can get them like between 2 and 3, it was perfect. The problem is you get your impedances down to 2, it's really hard not to get your impedances so low that you are literally almost drawing blood from the jump. Like as soon as you do your prep and you get that lead on, take the lead off, you can see some fairly significant impact. I say this personally because I prided myself as a young clinician that I got a great EEG. And I sure did. And I can look back and tell you that I personally sacrificed some skin to do it because it was more, I didn't understand the skin. I didn't understand the impact. And as mentioned, I worked in pediatrics. So I'd go back 2 days later to do a follow-up EEG. I didn't have to measure, which now like makes my heart hurt because I could see exactly where my leads were because I abraded too aggressively. ASET's done a great thing for our field to make a comment about raising up the impedance levels, get them up to 10. I mean, you want them as balanced as possible, but they no longer have to be, under 5 and at 2 to 3, ideally. So impedance is important. This slide, I'm not going to do anything except just to say at your leisure, like take a look at this slide or jump into this information and familiarize yourself with it. Our products, our capital equipment use differential amplifiers, which means they want to amplify differences, and that's what they want to put on the screen. And because they believe that if you're looking at really clean, non-artifact data, that the differences will be your spikes and your sharps and all those wonderful things that we want to see in our EEG stream. Also, if your impedances are balanced, the amplifier uses something called a common mode rejection feature. And what that means, if something is common coming in to the stream of the amplifier, I'm going to assume that's artifact and my equipment's going to help me clean that up a little bit. Now, I'm super simplifying it, but long story short, if you have a patient that you have significant concern about skin health, and you're even concerned about keeping impedances around 10, talk to your administrator, talk to your physician, talk to your manager, because if you need to keep those impedances even higher, at 15, at 20, as long as they're balanced, like within a couple of kilo ohms of each other, the noise coming in is going to be common. So then the amplifier is going to kick that artifact out and give me beautifully clean data to show me the difference. So meaning the amplifier's function supports keeping impedances a little higher as necessary. And that's a little bit where ASET got the comfort to finally raise the recommendation from 5 kilo ohms to 10 kilo ohms. So any more questions on the amplifier or whatever, happy to answer it later. But there is a magic connection between that. And again, and this is just a little summary really of just what I just said there. Last couple pieces here as well from my side, and that is, the interface, to the amplifier, know your equipment really well. Because again, we're all after clean data. We have to have good, clean EEG data, but know how your machine can help you. Talk to your manufacturers. Talk to them about, artifact and impedances, because again, it allows you that knowledge to help protect that skin. Medical devices. What we use, folks, is a medical device. Our EEG electrode is a medical device. It is a class 2 medical device. And this is regulated, meaning there's a reason why our electrodes, over the course of time, hadn't really changed much. Like they were all still reusable until about 15, 20 years ago. Then they all kind of, started to transition a little bit to a disposable. And one reason for the disposable is because of the fact we were acknowledging we're putting these products on non-intact skin from patient to patient. So I got an outpatient, EEG study. I used my, reusable product if I didn't disinfect it properly, I then took it to the ICU to my 3-year-old, who again, I'm putting on a non-intact skin. So it is a medical device. Again, for time, I'm just going to like introduce these slides. Feel free to look through them on your own. Feel free to ping me for any questions. But it is important for you to know that what we use is a significant design and development and FDA regulation. We are class 2 medical device. We are seen this way in the eyes of the FDA, the CDC, everything else. So what we use is important. We are not just, the little group that comes down with our portable machines anymore and does some study that doesn't matter. What we do really matters for the patient. Last couple ones, and then I'm going to hand it over to Sarah. So again, we talked about this a bit, and Sarah's going to talk more about it from that clinical side of things and like techniques and things. Remember, we're doing non-intact skin. Remember, you're using an abrasive. Look at your information for the manufacturer that you're using, because that manufacturer can also give you some fantastic advice as well on how to use that properly. Remember, different electrodes, it does matter. Now, everything you see on this screen, some of them are flat, as you can see, some have a rim. It's okay about the rim, but just look at the rim. Ask your manufacturer, the wider the rim, the better. The flatter the lead, the better. The less pressure, like from connecting to the electrode to the lead wire, the better. All these little areas of the electrode matter. And so you've got some choices. So as you look in the market, take a look at all the manufacturing options that are out there, because also this matters when you leave leads on for a significant amount of time. It's one thing if you're doing an EEG for 20 minutes, we're impacting that, the skin for that period. But now I'm putting leads on, I'm keeping this patient on for 4 days. So that rim and that shape really start to matter. The patient's going to the MRI and coming back and having leads remained on, not taken off, not taken back, put back on, which is ideal. You still have to maintain that skin integrity under that electrode, kind of under the hood. Every part of the design matters. So, this is obviously an example where there was like extensive, significant pressure where the lead wire was. So make sure like where those lead wires run. And again, Sarah will do a great job of, giving her clinical experiences and expertise on how to avoid this kind of thing. But step number 1 is you've got to be aware of it. It's the entire assembly. It's not just the electrode. It's that hub in between. It's the lead wire. It's the entire thing. And last but not least, I'm not going to touch on reusable electrodes, except just to say that reusable electrodes, if you are using any still in your service, you have to be disinfecting them properly, because according to the CDC, they are considered a non-critical item, which means you have to have a protocol that matches a semi-critical disinfecting process. So again, my days of when I started an EEG and we took our leads from one patient and I put them in some mystery solution and I let them soak while I went and got my next patient and brought them out, that no longer works. That's no longer okay. It should have never been okay years ago either, but we didn't know any better at that time. The field knows better now.
Leah, they're a semi-critical item, you mean?
Oh, yeah. Did I say critical? Yeah, semi-critical.
You said non-critical.
Yeah. So it's a critical topic. So anyway, yeah, semi-critical. So there you go. Thank you. So again, and this is just references from ASET again. And part of it all rolls to the part of our business that I know we don't want to think about or talk about. But, if a patient has EEG, say they've got an EEG, monitoring that session that goes on, there is a healthcare acquired infection that happens. They are going to assess that patient and figure out how did that infection happen. I have now, say, 21 locations on the patient's scalp, which have non-intact skin. They're going to be looking really closely if there's any chance that those electrodes on those spots of the skin could have been the source of a healthcare acquired infection. And the reason they care is because there is financial impact to a facility that has healthcare acquired infection or healthcare associated infection. It costs money to the facility because they don't get paid then for a certain part of the process with the patient. So this is why you've got people that kind of know nothing. So you kind of feel like know nothing about your department or what you do every day. Sometimes suddenly coming into a meeting and they have some big opinion on what you're using. Well, they got a big opinion because at the end of the day, it does have financial impact if you're not protecting the patient's skin and then ultimately knowing the skin, the device, what you're using it for, and again, like how you're handling that entire process. All right, and I'm going to stop there. And I'm going to pass the baton to Sarah. And Sarah, I can be your slide girl if you want me to be.
Okay. Uh, go ahead. So again, just talking a little bit about the JACO, the health acquired infections in the hospital. I had a little noise on there, just kind of alerting. I don't think we heard the sound, but it just kind of a fire alarm alert, because typically when JACO walks in house, most of the time we know it immediately. Messages go out, everybody's aware. Your leadership comes around letting you know. And they're looking for things such as your Q-tips. Are they in a sealed bag, or did you open up that paper bag and you've got it open? Your electrodes, are they in a sealed bag, or do you have them hanging and dangling on the wall behind you, or wadded up, on the counter or in a drawer? They're also looking for tape. They do not like tape. We have to use tape. I know it's a reality, but they don't want to see that tape torn and hanging on the edge and on the side, even if you do have a patient that you're walking out to go get and bring right back. They expect us to tear it as we're using it. And I know one of the facilities I worked at, the techs were really great about making sure they put a towel at the end of the bed to cover that gap, because you don't want electrodes to fall on the floor or to fall in between things and get caught. And then especially a family member, a mommy, daddy, see you pick that electrode up and then put it on the patient. Oh, it went through a whole bunch, Leah. Sorry. Okay, there we go. So
I'm gonna lose my job as a slide forwarder. I'm so sorry.
just wanted to share with everyone and point out here that 1 out of 4 reusable EEG electrodes are contaminated with a pathogenic bacteria. And this is why ASET did that research, and Anna Bonner as well as Petra Davison. They rewrote some of the information to update it more from when Lucy Sullivan first started it. So this has been a huge initiative for ASET to really, as I've been in the field 21 years now, for everyone to understand that this using reusable electrodes, especially if you're not cleaning them according to standards, and we all get in a hurry, we all have to go back to back, we're short staffed. We got to hurry up and clean the electrodes and go to the next patient. We got stats and tons of patients waiting on us, but it is definitely a hazard to our patients and not always safe. So I'm sure everybody's very much aware of like the setups here of everything we need: collodion glue, 1020 paste. You may use other conductives, which we're going to go through in the next couple of slides. Your tape measures, your Q-tips, and your head wraps. So we're going to go through each of those now in the next few slides. And these are all the tools that we use. So up on the top, you will see some disposable markers. They come in different colors. These are one-time use. You can use them, toss them, as well as the tape measures. There is the one-time use, the paper tape measure versus the retractable. I get it. Every time I use a paper, it rips, especially in ICUs. And so if you use a retractable, I usually have a couple. That way You can wipe it down with that Oxivir, or if you're still using Cavicide, whatever it is at your facility, and make sure it's nice, soppy wet, and then let it dry the time frame that it's supposed to, like that 3 minutes, and don't retract it back in. Also, the markers on the right-hand side of your screen, the wax markers, the Sharpies, those are kind of like what I used to use when I first started out in school. They gave us all one, the wax pencils, as well as the pencils on the top left corner that you can replenish the leads in them. They all come in different colors. Again, you have to be cognizant of what exactly you're using and then how you're cleaning it if it is a reusable. So I did put the YouTube link in here. I'm sure if anyone's ever been to a conference and Miss Patty Baumgardner that hands out the 1020 and the new prep for you, there's a nice little video on YouTube that Weaver put that kind of explains how to prep and place the leads. I very much like new prep. I have also used lemon prep. I know when I first started out early on, I had seen some techs intermix those, especially for like those cases where we had dry blood from an MBA or a surgery, recent surgery. And then it was explained to me by my mentors, you really should not mix products. So I have used lemon prep on its own too. It is grittier. Be very, very careful about when you're scrubbing and how much pressure you're applying and how much exfoliant there that you're using. There's other products out on the market too. There's the pink, usually used to get it from NK. I don't know if they still do, but it's for sensitive skin. And then the Pedia Prep. So there's lots of different products out there that you can use for the exfoliant to abrade the skin. Just be mindful of the pressure, and as ASET states in their articles, to make sure you're not directly up and down, you're kind of at an angle. Don't cause friction going back and forth, as well as be careful of your Q-tips, whether you want to use a long one or a short one. What you really need to pay attention to is the cotton on the end. I've seen where sometimes, whether it's a plastic or a wood, that it will go all the way through that cotton, or that cotton's kind of coming off and it's not hanging on there real well. And maybe it's just a temporary, issue, or maybe it's a long term. But in any case, you want to make sure that you definitely are paying attention to that, because you don't want to scrub the patient's head with something that has the wood stick or the plastic stick coming out. So also there are some other advances that have been coming into the market. So there's some like skin protection, so to speak. I don't know a whole lot about it. It was just coming in the last couple years, the Mepitel. They're skin barriers. So if you attend any ASET conferences or know anyone, I know in 2023, I believe it was, in Phoenix, ASET had a children's hospital there, and I can't think right off the top of my head which one it was, but they presented on using Mepitel underneath the electrode. It's got tiny little holes, and they were getting good results with that. I think that this is something, though, you have to talk with your hospital, you have to talk with your team, you have to get approval to use things, as well as reach out to the manufacturers and find out if it can be used the way you're wanting to use it. And for our conductives, so as you see down there on the bottom, I think if you do one more click, Leah, there we go. it's kind of slow coming in, but the cross. So back in the day, years ago, we used to all just dip out of the jar, and then because of infection control, we started. I always used a tongue depressor out of that big jar and would put it on the back of my hand, and I kind of work that way. Everybody has their own techniques. That's what's great about working with different people. You get to learn different things. And you definitely want to make sure if you are still using big jars, if you have not went to single use, that you are taking proper precautions to make sure that you're not causing any type of an infection from the EEG if you know it was to be cross contaminated. So go to single use, use tongue depressors to dip out that 1020 out of that bigger jar. They also come in tubes, Elafix, 1020, Tensive. They can all come in tubes where you can kind of squirt it out onto a paper towel. But these are all different conductive products that you can use. Some are thinner, Signa cream. We used to use the blunt tip there and refill the electrodes when they're long-term or in the EMU, and they've been glued on. That's why you make that little hole with the air hose in the cup electrode there so that you can squirt that in later. Definitely don't abrade with the blunt tip, or I had even seen one time a sharp needle being used on the syringe. You definitely don't want to do that. We want to try to protect the skin as much as possible, yet still do our job and get a good study and take care of the patient. There's also adhesives out there so that we can place whether it's a flat electrode or a cup electrode that you want to use right on the forehead, on any skin areas behind the ears that are very sensitive. HipaFix is one I love. It's breathable, but there's also other tapes that can be used. Over my career early on, I used other things like the silk tape, paper tape when you get those patients with the allergies. Transport tape, I typically tend to save not for skin, but for my head wraps. It's easy to tear and to get into if needed later on, but it's just not something I particularly like to use on the skin. But there's lots of tapes out there that we also utilize when we're setting up our patients. The cushions are very nice. I've had experience using the cushions on the forehead for patients. Sometimes I've even had the cushions, though, leave a little bit of a red circular mark on a patient. So again, be careful when you prep for on the forehead and want to use a cushion. You need to prep with whatever exfoliant you want to use and then wipe that excess off. And as you wipe that off, and then you can feel kind of the tackiness on there, then you'll place your cushion, and then you'll fill your cup electrode or your flat electrode with some conductive and set it just right on top in that circular. And you can either glue it on, HipaFix it on, whatever your choice of method is. So I wanted to show this slide. Leah and I were talking. A lot of people, when we're talking to techs at conferences or just in general, I've heard the collodion glue and the conductive being interchanged a lot. Some people, even nursing, will think the collodion glue is our conductive, and it is not. The collodion glue is an adhesive. There are a couple different kinds of collodion. There's the HV, the high velocity, which is thicker. And then there's two others I can't think of right off the top of my head, but one's very thin, kind of watery. Always make sure you wipe off the excess off your gauze when you're gluing that down. Make sure there's no exfoliant around that it's not going to stick to, as well as conductive, but it's an adhesive. Now, if we flip gears here a second, it used to be called EC2. Now it's SAC2, and then the ACP. They are a conductive as well as an adhesive. So if you've ever used it or if you want to try it, it does get a little hard and almost cementish. And then it says that you need to use warm water to get it off. When I tried the EC2, I personally did not care for it as a tech setting up EEGs, but everyone I feel needs to try out, whatever you're interested in and see for yourself. But again, the SAC2 and the ACP are conductives and adhesives, but your collodions, no matter which of the three you use, the collodion is just an adhesive.
Yep, and Sarah, I'll add one note to that as well. Is I used to use a lot of like the EC2 kind of versions, and just yeah, as Sarah had mentioned, remember it is your full conductive. So if you're using it as your conductive, kind of under the hood of the electrode, and then all over the top of the electrode, and then sometimes like some extra around the edges because you really want to keep it on, everywhere that you're touching that, like that cream to that conductive to is trying to conduct data. It's trying to take data and send it to your amplifier. So if you use too much of it as well, because I used to love using it and I used mountains of it. So same thing. I had somebody who was better at it than me once tell me like, hey, you should probably back off how much you're using because everywhere you're touching with it, you're pulling in information. So you could be pulling in artifacts. You also can make your recording area much bigger. And so, you got to be careful with the whole salt bridge thing of like, the patient starts to sweat or something if they have a head wrap or something, and you can actually create, one common area versus two distinct areas to record from. So anyway, long story short, just from my own personal experience, I loved it, but you do have to be careful. I liked it too much for a while.
Thank you, Leah. That's a great call out to keep in mind. We always want to make sure, same thing when you're scrubbing with your exfoliants and even using your regular maybe 10-20 paste like I did. You just want to make sure that you're just not putting big old globs on and squishing it out everywhere because as Leah pointed out, regardless of what conductive you use, it's going to conduct all over. And you just don't want to cause any salt bridges or shunting. And then for this slide, I wanted to show that also there are some methods to remove the collodion glue, and that is the Mavidon remover, which is more oil-based, and then the acetone, which I know a lot of people do not like the smell of the collodion, and then the acetone they hate just as bad, if not more. And then the shampoo caps, one of the facilities I worked at, a pediatric hospital, we started using these because those ICU patients and that, they can't get up and get around and take a shower afterwards, get that gunk out of their hair. So we would try to do it the best we can. And then they have these shampoo caps that you can just heat up in the microwave for a few seconds and then put it on and it just shampoos out. And the reason I bring that up too is because I'm not a big fan of the collodion remover, although I worked with a lot of techs that are. That oil base, you need to keep in mind, and in those ICUs, if you have to, if you're not using electrodes that are quick disconnects, and you have to take electrodes off and then put them back on, as well as maybe they had an EEG last week and now, this week they're going to have another one. That oil residue can still stay in that hair because, again, they're not able to get up and shampoo and stuff. And so that's where the shampoo cap comes in handy because that oil is just horrible. And then you're really trying to get your impedances down and you're scrubbing more and you can really irritate that skin and break it and cause potentially cause an infection. So just be careful with that collodion remover that's oil-based. Acetone I love because it immediately just dissolves the adhesive, the collodion, and takes it off. As well as you got to be careful if you put any water near the collodion when you're removing the electrodes, it will cause like little hardened white pieces. So just try to make sure you get all the collodion out before any water touches the hair. And then head wraps. So we all like our head wraps. We like to keep our electrodes in place, whether it's for, a 20 to 30-minute routine, or if it's for an extended study. We like to make sure we're keeping all of our wires kind of bundled together so that we're not picking up all the electrical interference and artifact. And so just be mindful. I have seen like 3 layers of head wraps before. It's not uncommon sometimes for techs to use 2 because they're also trying to go down the wires. And so I hear some like Spandage, some like Curlex, the tubular gauze that's like a sock. It's nice too. Whatever way you use, whatever product and how you use it is up to you. Just be mindful, as ASET points out, to make sure that you can put 2 fingers up underneath that. And especially again, for those NICU babies or ICU patients, that if there's any edema or swelling, that somebody's keeping an eye on that. ASET states in their literature we should be doing skin checks every 24 hours. I believe as a leader in the hospital that you need to set up your own protocols, what works best for your department for your patients and your staffing. And so if it's not every 24 hours, we at least try to go up there every other. Sometimes, though, it also depended on the actual patient. You've been around long enough to know your hospital and your patients, and maybe you need to check more frequently. And especially talking with your nurses, really partnering with them, and they're part of the team, the bedside nurses, and making sure they're helping you keep a check on it, that if edema does start setting in and swelling, that you're able to go up there and rewrap that head or loosen it, or maybe they can if you're not in house 24/7. Coban. So this is a huge one. Years ago, that there were techs that really liked Coban. I am not for Coban at all because it really tightens. You think that it's not, you've got it kind of loose, but I've seen it tighten. And whenever there's pressure on those leads, that's gonna, regardless of what lead you're using, that Coban tightening or edema setting in is really gonna affect the skin and be a potential for breakdown. So no Coban if you can help it, please, for the sake of your patients. And as I was talking earlier about the skin safety checks, ASET has done wonderful information on this. It's on their website, so you can definitely go to that and look and see what works best for your lab and how you can make sure that you're following this to the best of your abilities, because we are all short-staffed. We all understand. So it may have to be a little bit different of a rule for your lab, whatever your lab protocol is you set. So if your lab, does your lab have a policy? And if not, you really need one. So you need to sit down with your medical director and your team, and just really have a good talk about what policies you should set up for your skin checks. Leah was going to talk a little bit about this one too.
Yep. So I'll make it really brief, but again, everything that we've been talking about, related to the skin and your device on the skin, the impact to the skin, most of it's related to your longer term studies. So, if you're in a facility or if in a service that you've got inpatients, and whether you've got CT, MRI, some other kind of imaging going on, depending what kind of lead you use will make a difference whether you have to take that lead off, then re-prep the patient and apply leads back on after the study, or you leave them on. But either way, like, meaning if you have to take leads off and put them back on, you've got a whole bunch of other issues going with skin integrity, because you can only prep so many areas and try to, as the asset information kind of mentioned, like shifting your leads a little. They've got portable MRI machines now that can come bedside. They're not as good as studies and they're a lower strength, but they can come bedside. That means studies for MRs can get done really quick, really fast. I sat in a presentation once years ago in Texas where there was a physician that said, get ready, MRIs are going to take over the frequency of CTs and X-rays someday. And it's coming. Like if you're not seeing it right now in your service, you're going to feel it soon. So having leads on the patient that can stay on for an MRI or CT or a portable MR is critically important. But then you've got to remember the impact of leaving those leads on in a longer term setting for all the things that we've mentioned during this whole presentation. So that's the only reason I wanted to mention the MRI. It's really hard to talk about skin and skin health for the length of a study without talking about the most immediate issue that we have that's growing in our field, and that is imaging.
And especially, I'd like to tack onto that. So I've spoke with a lot of techs over the last few years that MRI's really gotten more prevalent, and everybody is getting an MRI. Is we're short staffed. Not everybody in the hospital is aware of that and understands that. And so if we can put something on even before they have to go to MRI, if we can get to them and get those leads on so you're not sitting around waiting and because you've already worked your shift and now you're on call, but you've got to wait for the patient to get out of MRI. It just really helps if you can start getting those leads on, the sooner the better, before they even go for that first one. As well as I learned in my last job in leadership at the hospital that a lot of other healthcare, nursing, for instance, even your imaging and what have you areas, other departments, they don't have the same type of call that we have. So we get called in and we do the patient, we take care of what we're called in for, and then we leave. And then we may get called back, we may not, or regardless, we have to be there the next morning for our shift. So we have to work the shift all day, typically that we're on call for, and then work the next day. And I found in having those communications and opening up that, that line of talk with the other departments, they weren't aware of that until I started letting them know, because when they get called in nursing, for instance, they're there for the whole shift. They work that whole shift then. They don't leave and come back. Same thing with some of your imaging, or they may have somebody else take over and they don't have to work the next day. So just make sure that you're talking to everyone that you work with in the hospital, all the different teams and departments. So again, that you're doing what's best for your team and your patients. And I know we're running out of time here. We just have a couple more slides real quick. Hopefully you can stay on. So at the last facility I worked very closely with some great nursing, and we were able to come up with a skin integrity skin assessment tab in our Tech Navigator. So they gave me permission to share this, and they also told me that if this is something you're interested in, that typically any institution can reach out to the EPIC technical support, TS, and they can reach out to Memorial Healthcare System, MHS, in South Florida, and they can help build one. They can share, what they did and how they did this. But this was an excellent tool for our techs to be able to put in their skin assessments. So it wasn't just in the EEG, and it was not also just in the instant report or anything like that.
And this slide, we just put it in here. So this is an example of just fantastic information that's available in the field. So I was years ago at a couple different conferences, and some different posters were presented. This is just one example of, I think, just an amazing, fantastic set of information. So as you leave this presentation, you want to go do your own research, look up some of these. They're readily available, on the internet, and, some of the conference information. And all this information is just really, really well done. has great tips, gives great information, helps support the conversation you're going to have with your manager and administrator. So that if there's some additional products, like Sarah just mentioned, that you might want to try for skin as your backup, you have a voice. And because you're the front lines, you get to exercise that voice. So, just this was just an example of just a great poster, and there's tons of great information out there.
And you have this slide too, Leah.
Yep. So this was just, again, just another example as we finish up the presentation to remember that skin integrity impact can look like a lot of different things. Looks like different things on different patients. So, just again, refresh with your demographic, whether you're doing pediatrics, adults, outpatient, inpatient, ICU patients, geriatric patients, whatever it might be, just, look up, start to document how your patient's skin looks so that, again, as Sarah mentioned, you start to create your own protocols, your own guidelines, your own recommendations for protecting skin health. And you're going to have lots and lots of support of this in your hospital because, as mentioned, this continues and will continue to be a hot topic in your service and in the hospital.
And just about 2 or 3 more slides here. So this one is I got permission from UF Health EEG department there to share this. This was handed out at AES. My medical director shared it with me back in like the early 2020s. And just, again, a great card. I would like to see all of us have the same kind of card because wound care gets called. They're not used to seeing anything on the skin from our products. They're used to looking at bed sores, ulcers, that kind of thing from other devices. So just trying to partner and have someone else look at it. Dermatology, Leah always recommends, but there are some cards out there that UF Health came up with. They're going to revise this and revamp this, Robert told me. And I'm hoping that I can work with him on that because I would like to see this out here for all of us. So we're all on the same page and know exactly what number 1 is to every single one of us, regardless of what hospital you're at. And then these last ones were just some skin breakdown. Some of it, as you can see in number 2, that's from after the collodion remover, that oil, it gets kind of pimply and red. It's not a skin breakdown. The skin's not broke there. In number 6, you can still see some of the red marker up in the hairline. Number 1, you see the indentation from the hub. So maybe it was too tight when it was wrapped around the forehead. Number 7 was by the eye. It did have skin breakdown. It's kind of scab in there. So just there's different things and we want to make sure that we're all calling it the same thing. So I would really love to do more work on this in the future.
And there we go. We're on the last slide. We will hang on for a few minutes. We'll try to grab like 5 minutes of questions. But this was just a summary of hopefully what you pulled from the presentation and, hopefully kind of, got you thinking about skin and devices and all that we're touching with our patient and, maybe introduce some different questions that you want to ask in your service or things you want to implement or extra information you want to share with others. Maybe you found some great protocol that has really good success. As Sarah kind of mentioned, that shouldn't be kept just to that one service. Like we should be sharing it with everyone. So anyway, hopefully you kind of, got a good feeling of how the information was provided, and hopefully it was kind of thought provoking for you. So with that, Sarah, if you want, what I'm going to do is because I don't know how to get to the chat questions with the screen up.
So I've got a couple. Yeah, I've got a couple,
okay.
Leah. Thank you, everyone. If you've been able to hang on, we appreciate it. We listened to you. You said you wanted Skin Talk webinar. So that's what Leah and I, put together for you today. I hope you enjoyed it. And, that's what Rhythm Link's all about. We want to partner with you and make sure that you're getting the education you need. So one of the questions, I don't know if they're still on, Leah, but they had talked about covering bald chemo patients.
Yeah, so when you're doing an EEG study on a bald chemo patient, you've got a variety of different factors in there. As we just talked about, you have a different skin challenge. It's not just the fact that just because there's no hair there, you've got then development of other layers, but you also then have the impact of the medication of chemo patients as well. In my experience, that this is where usually the impedance conversation is super valuable. Meaning, like, depending on what the demographic is, whether it's children, whether it's adults, whether it's older patients, I would recommend trying to track if you are seeing any breakdown, any skin integrity impact at all. Start really tracking that, and then try to figure out for those particular patients who have less hair or are bald and are going through some kind of treatment, such as chemo, because there's a variety of different kinds of medication, of course, for chemo. Try to then track that so that you can come up with a specific policy and procedure for that patient demographic. And many times that has to do with prepping less. So meaning you're keeping that, we talked about keeping those pieces a little higher, but balanced. Remember, balanced is the critical piece. You're going to get beautiful, clean data if you keep those impedances balanced. So without knowing two other, more details about the question, that would be my initial recommendation. Track it really well, and then talk to your service and your folks around you about if you're seeing skin impact. First, I would look at my prep step, and I would look at my impedances and try to see if there's a mix there that's healthy for the patient yet gives you good data.
And we had one question, Leah, Diane L. Good for Laplacian hookup? Question mark.
So, yeah, so if you use you can, and I'm assuming that this is referring to a difference in reference. So if you're doing a difference in reference, this is where your capital equipment, I hope I'm understanding the question correctly, but this is where your equipment can help you, because your equipment can also, like, especially like if leaving impedances higher, maybe you're in the ICU, or you got an inpatient scenario, you're battling with artifacts. You can use different kinds of references so that you can try to eliminate, again, that artifact, which is common coming in to see in the amplifier. So long story short, without getting too deep into the amplifier, hopefully I'm understanding the question correctly. But if it was about using a different reference, especially as it relates to that amplifier function, 1,000% be researching what you have at your disposal from your capital equipment vendors. Use a piece of data that's already recorded, especially one that's maybe got a little artifact, a little dirt in there. Mess around with impedances, I'm sorry, with references. Understand what you're changing, though, in your display, because I'll stop there a little bit, because you can change your display to either enhance something or get rid of something. And that includes real data. So, long story short, yeah, definitely good for using different references on that capital equipment for the common mode rejection and that differential amplifier.
And then there's a question, how to prep burnt patient with sensitive skin or no skin?
So that's really tough. So I trained at the University of Iowa's program. They had, at that time, and they probably still do, a very aggressive burn unit. And so we ended up using needle electrodes, because if there's no intact skin at all, and we used to have, and I can't give the University of Iowa program enough credit. Like, this is just one of the best programs. I'm crazy biased, but one of the best programs in the country. And every patient, we'd have to have a conversation. And of course, at that time, I was a student, so I really didn't know what I was doing, looking for every guidance, and every situation was different. If there's literally no skin, like if the skin has been damaged to the point that you don't have any surface, there's not unless someone has a technique that I haven't seen in 40 years, there's not great strategy to be able to use a sort of a typical electrode in those situations effectively. So that's where, we would use needle electrodes because, and then you have to be very careful with placement because again, your goal is just to elicit the EEG data you want. You're not trying to get like super deep into structures like you might in the IOM environment where you're looking to get down to generators and things like that. So it's a tough question to answer because it really is patient by patient. But if you're being asked to do an EEG on a patient that like has had such damage, I would immediately call the referring physician, pull in your neurologist, if that's not the person, pull in other folks and have a conversation first. Because your information is just going to be crazy limited if you don't. Like what you can provide them that's useful.
And the Laplacian, I know everybody, we've got a lot still staying on. So the Laplacian comment from Diane was regarding excess SAT conductor.
Oh, okay. Yeah, I don't know as much about that, to be honest with you. So that one we can, Sarah, unless you got information on that, what we can do is I know we can pull some information and respond to that like after the presentation, but I probably don't have a good answer for that one.
Yeah, I know there's some other comments here talking about, so that was Memorial Healthcare System in South Florida, Hollywood, Florida. Their Epic team is who built that, what I showed on here. So you can reach out, have your Epic team reach out to their Epic TS tech support. And then I know there's some other comments of other people also sharing that they have such systems or even the cards, the flesh scale and that. If you have those cards, if you don't mind sharing those, I would love to gather information. And so that, again, we could work on something. I would very much like to see it across the whole country that we're all on the same page.
Might be a great
Um,
thing to just like when people say like, call your local politician and might be a good idea to contact your local asset people or the leadership at asset and sort of let them know that that's what the field would like to see is some consistency and guidance in that because that's exactly what they're formed for. And I think that would be a fantastic group to like gather all the great stuff, put a committee together or whatever, and then put it out there for the field for comment and sort of like evolution. But yeah, that I would like, I'd call the asset people too.
Yeah. And Robert Turner at UF Health, he's working on it. I see Jamie Grover shared that she uses Mepitel mainly under the frontal electrodes. Thank you, Michelle Olafson. She shared that it was Children's from Orange County in California that did the presentation at ASET I mentioned using the Mepitel under the frontal leads. So if I missed any questions, I apologize. Again, we had a little bit of technical difficulty, so trying to maneuver what usually Max, our amazing digital marketing takes care of for us. So please feel free to email myself, sbatson@rhythmlink.com, or Leah if you know how to get a hold of her. We want to make sure that, even reach out to your rep, your Rhythm Link rep, and then they can get information to Leah and I, and we can help you out with whatever it is you need.
Sounds good. Thanks everybody. It was
So,
awesome.
all
Maybe
right.
next time
Thank you for staying over.
we'll be in person maybe sometime.
Yeah. Be sure to fill out your questionnaires at the end so that we can find more great topics for you and you get your ASET CEU. You want to make sure you get that. So, all right. Thank you all.
See you guys.
Thank you, Leah.